Thanks, Anasua, for the introduction. So I'm Dr. Tarjani Dave, and I'll be presenting on conjunctival lymphoma, the diagnosis and management of it. Now, this can get a little theoretical because you need to know some amount of basic science to understand the conjunctival lymphomas, but I've tried to make it as objective as possible. So essentially, like every tissue, the conjunctiva also has its own lymphoid tissue in the form of T cells, B cells, plasma cells, and the dendritic cells. And this organized structure of the lymphatic system within the conjunctiva is what is called as the mucosa-associated lymphoid tissue, or the MALT. And this serves as the afferent arm of your mucosal defense system over the ocular surface. Has the mic stopped working? So primary conjunctival lymphomas if I'm loud enough, I'll continue. Looks like the mic has stopped functioning. Is it okay if I carry on? Yes. Right. So when I become too primary conjunctival lymphomas arise essentially from this mucosa-associated lymphoid tissue, and they constitute 1.5% of all the conjunctival tumors. So it forms a very small percentage of the ocular surface tumors in your practice. But what is of importance is that there is a 6% annual increase in the incidence of mucosa-associated lymphoid tissue lymphoma. So this is one take-home point from this slide. Now, this is the subheadings over which we are going to discuss today's lecture. Let's go through the first part, which is the incidence of Is this working? I don't think this is working either. So the incidence of conjunctival lymphoma is the first thing that we'll take a look at. Right. So it's difficult to segregate the conjunctival lymphoma by itself to find incidence from literature, but what you'll easily get is the incidence of ocular adnexal lymphoma, and what adnexa means is the conjunctiva, the lacrimal system, the eyelid, as well as the orbit. Now, ocular adnexal lymphoma forms 8% of all the extranodal lymphomas. And if you look at only adnexal tumors, the different sort of tumors that might arise from adnexal structures, lymphoma constitutes about 10 to 15% of all the adnexal tumors. And in this, non-Hodgkin's lymphoma is the commonest form that you'll come across. Hodgkin's lymphoma is extremely rare as far as the ocular adnexa is concerned. If we have to bring out the incidence, then there are certain publications from around the world which tend to suggest that amongst adnexal lymphoma, the orbit ranks highest, followed by the conjunctiva, followed by the eyelid. So its incidence is about 20 to 30%. And moreover, multiple adnexal sites like a conjunctival moltoma along with an orbital lacrimal gland lymphoma might be present in about 10 to 20% of the patients. These lesions are seldom bilateral, but when they are, simultaneous bilaterality is what you will see commonly, which means both the eyes will show you the disease focus at the same point of time. However, about 20% can throw up a subsequent bilaterality. Now, when you look at its association with systemic lymphoma, the eyelid lymphoma is most likely to produce systemic lymphoma, followed by orbital lymphoma, followed by conjunctival lymphoma. So if you were to say the conjunctive, if a patient has to have a lymphoma, he would rather have a conjunctival lymphoma than an eyelid or orbital lymphoma. Having said that, systemic involvement is present in about 17% of the unilateral cases of conjunctival lymphoma and 50% of bilateral cases. So the take-home message here is that if you're seeing bilateral conjunctival lymphomas, it is a must to rule out disseminated systemic disease. Let's look at the pathogenesis of lymphomas. Now, this is one interesting part here where you have infections related to the production of a tumor. And it's quite well known in gut lymphomas for the lymphomas to be associated with H. pylori infection. It's also known in the ocular lymphomas, and inflammation due to this infection can lead to chronic antigenic stimulation, which finally produces a genetic mutation and results in a lymphoma. Other than an infection, any chronic autoimmune disease or any other inflammatory trigger can produce this antigenic stimulation and lead to a lymphoma. There are certain studies in the West which have reported a rural residence or exposure to household animals and chronic conjunctivitis to be that focus of inflammation that has led to the production of a chronic antigenic stimulation and lymphoma. So this is the fourth point where an infection is related in the production of lymphoma. There have been several classification systems and stagings methods available for lymphoma over the period of years, which have taken into account the genetic mutations that occur as well as the morphology of the tumor. Of all of these available classification systems, quite a few of them fell into disrepute because they did not differentiate the B cell and the T cell lymphomas, or were systems which were not interchangeable in terms of international management. So the US follows a system, the European Union follows a system, but these are not available in a nomenclature that can be interchanged, and hence publications or research out of this tends to become difficult. Things changed with the advent of the revised European American classification of lymphoid tissue, which is now incorporated into the WHO classification, which divides lymphomas into the Hodgkin's lymphoma, the B cell neoplasms, and the T cell and NK neoplasms. However, you need to understand one thing here, that this is only a classification based on the cell type, but this does not help you get the prognosis for the patient, and moreover, these were not classification systems applied to the ocular adnexal lymphoma. This is what was given in general for the body. However, the Ann Arbor classification system did provide a staging for lymphoma where ocular adnexal lymphoma seems to be falling in the lowest stage, which has a better prognostic value. What is internationally accepted is the AJCC TNM staging. The 7th edition is what was released in 2009, but what is currently followed is the 8th edition, which was just released last year, which is not very different from the 7th edition. Now, of note here, as your T increases, the prognosis tends to be bad. And if you see, then our conjunctival moltoma falls in the lower Ts, that is in the T1, where the prognosis is relatively better. So as you have a lymphoma which is progressing from the ocular surface to the orbit, or is involving the eyelid or other adnexal tissues, bear in mind that the prognosis of the patient tends to go down. Let's look at the different types of lymphomas which are present. And essentially, these lymphomas in the conjunctiva, the place where they develop is related to the lymphocyte development. If you look closely at the lymphocyte, it has 4 zones of development. What you see in conjunctiva is essentially the development of the lymphocyte in the extranodal marginal zone and within the follicle, and hence you'll see that the extranodal marginal zone lymphoma forms 60%, which is the highest in conjunctival lymphoma, followed by the diffuse large B cell and follicular lymphoma. So these are the subtypes which you will see in the conjunctiva. The most interesting part which we are here for is its clinical presentation. Now here again, what we tend to see is presentation in relatively late life, that is between 5th to 7th decade. In our part of the world, we tend to see a female predilection, and usually you see a conjunctival lesion which is bulbar or fornicial, rarely over the palpebral conjunctiva. So the bulbar conjunctiva and the fornix tend to show more of lymphoma. It has a typically indolent course, and because of which it tends to masquerade other diseases, and clinically it looks like a long-standing salmon-colored lesion. It has certain other atypical forms of presentation like a ptosis or a patient complaining of foreign body sensation, irritation, or excessive tearing. But what we need to remember is its indolent course. This is classically how a lymphoma would look. So you see a fornicial and a bulbar conjunctival involvement. This on slit lamp is typically subepithelial and tends to be fixed. It's not very mobile. If you were to make an optical section, you might be able to see the sclera separate. Unlike scleritis, you won't see tenderness over here, and the patient's major complaint is only a mass lesion. Quite frequently, it's also accidentally diagnosed while the patient has come in for a regular ophthalmology consult. And the salmon color to this lesion is what is most pathognomonic. Certain times, it can even look like a faded salmon-colored lesion, which otherwise might be taken as a run-of-the-mill episcleritis. However, the points to note here would be that these patients typically don't have inflammatory signs and they don't have pain and tenderness. Also, if you were to put these patients on any form of treatment for episcleritis, you would not see a very good response, and also the clinical history will not give you the typical waxing and waning sort of a presentation. At times, they might even present like other diseases, like the very innocuous follicular conjunctivitis or a nodular scleritis, or at times might even mimic amyloidosis. But you need to remember that all of these conditions, all of these masquerading presentations have the classic indolent course and no waxing and waning and no pain. When we look at diagnosis of conjunctival lymphoma, essentially it is with the help of biopsy and histopathological examination of that biopsy. However, you want to know the extent of the disease, whether there is associated lacrimal gland orbital involvement or lacrimal sac involvement, and you might want to do a CT or MRI for that. For an accurate tumor staging and prognosis, you need to order systemic investigations. The role of biopsy could be either incisional or excisional. If it's just to, if it's a lesion which is a well-defined lesion and is within the boundaries of a complete excision, that is always preferred, followed by subjecting the lesion to histopathological analysis. However, if it's a diffuse lesion, like we saw in the earlier presentations, an incisional biopsy followed by an adequate tissue diagnosis might suffice. When we look at the treatment of conjunctival lymphoma, there have been several modalities reported. For very small tumors, when you have a tissue diagnosis of lymphoma, even cryotherapy can be considered. However, if the lesions are larger, you might consider an excision biopsy if it's a well-defined lesion. In lesions which are poorly defined, external beam radiotherapy has also been put forth. For systemic spread, chemotherapy needs to be given. There is recent role of immunotherapy, however, its long-term result has not been proven. And also antimicrobial therapy, considering that its pathogenesis is involves infection with Helicobacter pylori, is also what is recommended. There has, for localized treatment, use of interferon and rituximab has been reported. However, complete remission of the disease is only reported in about 50 to 70% of the cases, versus which EBRT gives you remission in about 90%. You need to keep a watch for side effects of radiation. Systemic therapy is, as we have discussed, and one of the newest drugs available nowadays is Zevalin, which is a form of radioimmunotherapy for patients who have a systemic dissemination. This is the most important part of this presentation about prognosis. So what will you tell your patient when you have diagnosed and proven that it's a conjunctival lymphoma? If the lymphoma is in the eyelid or orbit, it has a grave prognosis compared to the conjunctiva. If it is a lower stage at time of presentation, the prognosis is better. If the lymphoma is of a low grade, obviously the prognosis is better, and this is what your tissue diagnosis will let you know. The role of Ki67 and growth fractions, P53 growth fractions within your histopathological sample, if more than 20%, gives a poor prognosis. Serum LDH is one systemic investigation which helps you monitor these patients, and if it is raised, again, it carries a poorer prognosis. So in summary, moltomas are conjunctival lymphomas that arise from the mucosa-associated lymphoid tissue. The masses are bilateral in 20 to 40% of cases, and when bilateral, do rule out a systemic spread. Isolated involvement of the conjunctiva portends a better prognosis. 20% of patients with initial localized lesion will have a dissemination of the disease. Infection is related in the etiopathogenesis, and think of systemic antibiotics. It has a typical indolent course. It presents sometimes masquerading a episcleritis or a nodular scleritis. Systemic screening is extremely important. Biopsy of the lesion gives you the tissue diagnosis, and we've discussed the poor prognostic factors.